Good morning, good afternoon, good evening, wherever you are. Welcome to another intensivecarehotline.com and intensivecarehome.com live stream. Also want to welcome our viewers that watch this, watch the replay and couldn't join live. Thank you so much. Now, today's live stream is about the topic of today's live stream is my 4-year-old granddaughter has been in ICU for 5 months on the ventilator. Help. And we're going to dive really deep into that specific issue today. Had an email from a reader. We're going to look into that very closely today. Now, before I go into today's video or into today's topic, just a couple of things you may wonder. What makes me qualified to talk about today's topic. I have been working in intensive care for over 20 years in 3 different countries. I'm a critical care nurse by background. Out of those over 20 years, I've worked for over 5 years in intensive care as a nurse unit manager as well. So I've really gotten intimate insights into how ICUs operate way beyond the clinical. Right. So, worked in as a hospital bed or resource coordinator as well as on a deputy director of nursing level. So I've really, seen the mechanics of how a hospital and an intensive care unit works in particular, seen all the challenges, whether it's on a financial level, staffing level, seen all the constraints and combining them in how it impacts on patient and family care in intensive care. For the last 10 years, I've also been advocating and consulting for families in intensive care all around the world as part of my intensivecarehotline.com consulting and advocacy service. I'm literally talking to families and ICUs all over the world almost every day of the week. I'm also the founder and managing director of Intensive Care at Home, and you can find more information there at intensivecarehome.com. We are basically providing an intensive care service in the home for predominantly long-term ventilated adults and children with tracheostomies, but also for adults and children on BiPAP, CPAP, or home TPN, or anyone that's medically complex and is in risk of going to intensive care or staying in intensive care. We can help with that as well. Now, if you have any questions that are topic related or intensive care drone related, please type them into the chat pad. If we have time, I will answer those questions, of course, and you can also dial in live on the show later if we have time. But in the meantime, let's get right into today's topic. Once again, the topic today is my 4-year-old granddaughter has been in ICU for 5 months on the ventilator. Help. And I'll read out an email from Cindy, who wrote this email last week. She says, my 4-year-old granddaughter has been in ICU for 5.5 months. She was involved in a car accident and has a spinal cord injury. The cord was stretched but not severed, and her lumbar 2 and 3 were fractured. The first 2 months she spent in UC Davis, and the remainder of the time she's been at Shriners. She was on a ventilator for the first 2 weeks, then off the ventilator for a month. During the course of that month, her feeding tube became dislodged and the nurse fed her and administered her medication into the lung. Oh my goodness. She ended up with an aspiration pneumonia, and we were advised to have a tracheostomy placed for secretions. That's the only time she would need a ventilator, would be for the surgery of the tracheostomy placement. She was shortly afterwards sent to another hospital. They have had her on the ventilator since. She says her lungs are good and healthy, but she needs the pressure. As soon as they start to wean her, they have an excuse to keep her on it. The oxygen is measured at 21%, just like we breathe. And 21% of oxygen is room air. So the air that you and I are breathing is 21%. The hospital has PMR doctors running the place, and most of the doctors there are contracted out of the hospital that she came from. They have misdiagnosed my granddaughter from day one, stating she would not be able to move or have any mobility or cognitive ability. My granddaughter is considered the miracle child, achieving leaps and bounds. They say she can't eat food because of her swallowing. She can swallow. She asks to use the commode, but they won't let her, saying she has no feeling. But she does. Every time a suppository is placed, the child squirms and is very uncomfortable with it. They don't spend but maybe a few seconds every few days. They do not even know this child, and I feel, and so do all family members, that they're making this child an invalid. When she wants to heal with their help, we need help. Her emotional state is starting to deteriorate. I feel like they're doing this to her. Where do we go from here? We've asked Boston Children's Hospital to see her, and they have said yes. The hospital here will not help starting the transfer. Please help. Okay. Cindy, I am incredibly sorry about your granddaughter's situation. It breaks my heart to hear what's happening here. First off, sounds to me like the nurse made a big blunder there, and that's probably not even the right word. It's more than a blunder, by giving her medications into her lungs. So they must have misplaced the nasogastric tube going into the lungs, and then the nurse must have administered medication into the nasogastric tube, assuming it's going into the stomach, but it obviously went into the lungs. I have seen this very rarely happening, that the nasogastric tube is not in the right place, i.e. in the lungs, and then feeds or medications are administered, and it causes, an aspiration pneumonia, and that is really, really bad. That in and of itself is probably some form of negligence, because it sounds to me like prior to that, despite the L2 and L3 fractures, that she didn't need a ventilator, and she shouldn't. And they say her lungs are good and healthy, but she now needs the pressure. As soon as they start to wean her, they have an excuse to keep her on it. Well, the first question that I have here, Cindy, is what are her ventilator settings? Is she on BiPAP? Is she on CPAP? Is she, in a controlled mode, like an SIMV mode or a CMV mode? That's the first question. If she's breathing on CPAP or on pressure support, she should get mobilized, and she should be weaned off that ventilator, especially since she didn't need the ventilator to begin with, in spite of her L2, and L3 fractures. Now, I guess a bigger question here is, at what level of spinal injury do patients need to be ventilated, right? Now, from my experience, a C1 or a C2 spinal injury, which is the highest level of spinal injuries, patients need to be ventilated with a tracheostomy. Now, we've also looked after, and I'm talking about patients in ICU, but I'm also talking about patients in home care with intensive care at home. We have a C1 and a C2 spinal injury client at home, and they are ventilated with a tracheostomy. And we've also in the past looked after, I believe, C3 and C4 clients with a spinal injury, and they needed BiPAP ventilation intermittently. Now, an incomplete L2 or L3 fracture should not trigger mechanical ventilation, right? And this is pretty much what you're confirming. Your granddaughter was not on the ventilator to begin with when she first went into ICU after the accident. So, and now the question really is, why can't she be weaned off the ventilator? None of it makes sense really. Like I said, what ventilation mode is she in? That would be the first determining factor. What are her arterial blood gases? Is she coughing? Is she needing a lot of suctioning? Right? My only concern here with what you're describing is, they were giving her medications or feeds into the lungs because the nasogastric tube was misplaced. Did she cough? Does she have a good cough or gag reflex? Because that in and of itself should have been triggered as soon as she had feeds or medications down the wrong avenue, so to speak. So it's good to hear that she's on 21% of oxygen. Again, that's room air. So the air that you and I are breathing is 21% of oxygen. Many patients in intensive care, whether they are adults or pediatrics, are on more than 21% of oxygen. They're often up to 30, 40, 50% of oxygen or even more. But again, it comes back to blood gases. It comes back to ventilation settings. If she's in pressure support CPAP already, you're saying she needs the pressure already. But why? If she didn't need the pressure before she aspirated, why? Well, I shouldn't say she aspirated. Someone caused an aspiration. Why does she need the pressure now? It doesn't make a lot of sense. You're saying they misdiagnosed your granddaughter from day one, stating she would not be able to move or have any mobile or cognitive ability. Well, you're telling me obviously the opposite is true. They say she can't eat food because of her swallow. Now, I can tell you, I know of one C1 spinal injury client that has a tracheostomy, is ventilated, and can eat and can swallow. Now, that's the exception to the rule, but I know of one. And your granddaughter should definitely have the ability to swallow and eat. Nothing stopping her from that. We have looked after C3 or C4 client in the past on BiPAP, and this lady was able to eat and drink, so no reason why your granddaughter can't eat and drink. I can only imagine that her emotional state is starting to deteriorate. You feel like they're doing this to her, and I can only imagine what that looks like. And you're saying, every time a suppository is placed in your granddaughter, she squirms and is very uncomfortable with it. What stops them from seeing whether she can move her bowels without needing a suppository, right? So I don't quite understand, and it could be that even with an incomplete C L2, L3, that the bowel motions or, the bowel motility is impacted as well. Maybe she doesn't need a suppository, but if she's on a ventilator, she would feel pretty uncomfortable to begin with. So, what are the next steps here? The next steps is, as I said, determine what ventilator settings is she on, right? What ventilator settings is your granddaughter on? If she's on low pressure support CPAP already, nothing should stop them from removing her from the ventilator. Here is another question. If with an L2, L3 lumbar injury or incomplete lumbar injury, maybe her diaphragm is impacted as well, and maybe she's got phrenic nerve palsy. The question is, does she potentially need a diaphragm pacer? Does she need a cough assist, right? ask them whether she potentially needs a cough assist machine. A cough assist machine is often used to get rid of secretions for patients that can't take deep breaths, but they don't necessarily need to be ventilated in order to use a cough assist machine, right? So, cough assist might still give her the pressure that she needs, either in the short term or in the long term, and hopefully she can breathe. And if she can't cough up all secretions, the cough assist will help her doing that. But it is important that she'll be weaned off the ventilator as quickly as possible. She'll be weaned off, the tracheostomy as quickly as possible. And that would help your granddaughter to feel so much better. It would help probably yourself and your family to feel much better. Now, I'm just looking up the medical history from one of our home care clients, where we have been asked to do a nursing assessment. Yes, so she, for example, has a C4, C5 spinal cord transection, and she's not ventilated, right? So your granddaughter's injury is even lower, so there should absolutely be no indication to ventilate her. And if she's been ventilated now for nearly 5 months, something's got to give here. And why are they worried about having a second opinion, whether it's from Boston's Children's Hospital or from anybody else? What's their concern, really, to have a second opinion here? They're torturing your granddaughter, and unless there is something that really triggers the need for ventilation that you haven't shared with me, maybe there is something else that's part of the injury. You haven't shared that, but if you haven't shared that, maybe type it into the chat pad once you see this video, and let me know whether there's something we're missing. So, and the psychological damage that's being done by leaving a child on a ventilator for 5.5 months, I mean, that's just incredible. I am not sure why they can't take the steps that she needs to take. I guess with spinal injuries as well, your granddaughter should come off that ventilator, and then she should get on to pediatric rehabilitation, so she can live her life, grow up like a normal 4-year-old should grow up, and not being stuck in an ICU on a ventilator. I mean, that's just terrible. Now, here is another thing, obviously, that you haven't considered yet. God forbid, if your granddaughter can't be weaned off the ventilator, you should consider intensive care at home. And you can find out more information at intensivecareathome.com. You are saying in your email she needs the pressure. There's a difference between needing the pressure and the breathing rate. Like a C1, C2 spinal injury patient needs a breathing rate and the pressure, because they can't trigger breath at all. In your granddaughter's case, it sounds to me like she can trigger breaths, i.e. she must be breathing on BiPAP, CPAP, or pressure support. And if she does, then she's breathing spontaneously. But why does she need the pressure? What else is going on? Is there something else going on? Is she still battling a pneumonia? Has she had a pneumothorax, God forbid? What else is going on that they haven't shared? Why she needs a ventilator for so long? Why can't they mobilize her, get her out of bed, wean her off that ventilator? What's the issue here? So, and if she, God forbid, can't be weaned off the ventilator, or if she needs the tracheostomy in the long run, let's assume she can't cough, can't clear her own airway, then consider intensive care at home. But I don't think that is even needed at this stage. She might need some level of care with the incomplete L2, L3 spinal fracture, but we need more information there to determine what the next steps are. If, God forbid, you need to look at intensive care home, we can send you intensive care nurses into the home 24 hours a day and replicate an ICU bed. But, I don't think that is what's really needed in the long run. I'm just trying to educate you on options in case there is a reason that I don't know, that you haven't shared, why your granddaughter really is on a ventilator and she hasn't been weaned off it yet. I hope that helps, but in the meantime, you should also keep reaching out to Boston's Children's Hospital and see whether you can get a second opinion. But you can also reach out to us again, and we can look at medical records because we need more information. We can look at medical records, we can talk to the doctors and nurses directly and really find out what's exactly happening there. So I hope that helps, Cindy. Let's move on to the next question, which comes from Ellis. Ellis says, my father had a heart attack in which the AED had to be used to resuscitate him. AED is a defibrillator. He is now in ICU and will not wake up. He has been there for 6 days. The EEG and MRI showed no brain damage, and continuous EEG showed some seizure-like activity. They put him on some anticonvulsants and some heparin. He also has a breathing tube. Theoretically, I'm aware he needs cardiac treatment, but this cannot be performed until he gets neurological functions back. He is also at a teaching hospital with lots of fellows and residents working with him. My question is, after 6 days of what I probably consider reflex movement, what is the short-term care plan going to be like, and what will the long-term plan possibly look like? We are just receiving the standard answer of all we can do is wait, with very little to no explanation of what next steps could possibly look like. Any answers would be gladly appreciated from Elise. Okay, great. What a great question, Elise. So let's break this down one by one. So the good news is there doesn't seem to be any permanent brain damage, which is good, which has been confirmed in the EEG and the MRI scan. But why is he not waking up? Well, let's make some assumptions here. It looks to me like he has been resuscitated fairly well and fairly quickly by using the external defibrillator. And that sounds like it was successful. You haven't shared whether your father went into cardiac arrest, into VT arrest, into VF arrest, or if he had his heart stopped. You didn't share any of that. Doesn't matter. It sounds to me like he probably had a VT or VF arrest if the AED had to be used. And then the next question is, did he have cooling therapy in ICU? If he had cooling therapy, he would have been induced into a deep coma for 24 hours to cool down the body to protect major organ functions, including the brain. And he might have needed to be paralyzed for that, chemically paralyzed. So what I mean by that is he would have had medications such as rocuronium, cisatracurium, vecuronium, to paralyze him chemically so that he can't move, right? Because when patients go into cooling therapy, they can shiver, right? And that could trigger seizures, for example. You don't want any of that. So that's why often patients are being paralyzed and really put in a very deep coma. So the first question is, what did he have for sedation? Did he have propofol? Did he have fentanyl, morphine? Did he have midazolam/Versed? Did he have a combination of all of that? And was he paralyzed? If someone is in a deep sleep, deep coma with opiates and sedatives and is paralyzed on top of that, from my experience, it takes longer to wake up compared to if patients are not paralyzed. That's number one. Number two, was he in the catheter lab after the cardiac arrest? Before he went into ICU, did he go into the catheter lab? Did he have an angiogram? Did he potentially have an angioplasty? Did Did he have his coronary arteries dilated if there was a blockage? Did they even look for a blockage? Did he even go into the catheter lab? If he went there, he would have been sedated as well, most likely, and he would have been intubated, so prolonging the intubation time and prolonging the induced coma. So is that potentially prohibiting him from waking up? Next, you are talking about him getting anticonvulsants because they found some minor seizures. So the question is, what anticonvulsants / anti-epileptic medications is he getting? Right? So is he getting medications such as phenytoin, Keppra, Vimpat, or any other medications that have sedative side effects? Is that potentially stopping him from waking up? Next, what's your dad's age? From experience, it's fair to say that, a patient's age, generally speaking, is a delaying factor in waking up. So someone at the age of 25 in a similar situation would wake up quicker as opposed to someone who's 85, right? Next question is your father potentially in kidney or in liver failure? And if so, is that delaying him metabolizing sedatives and anticonvulsant medications, and therefore he's not waking up? Or is he potentially in kidney failure and not excreting, medications such as the sedatives and the opiates that he's had, again, further delaying him waking up? Many patients in ICU go into kidney or liver failure temporarily. So these are questions you should be asking. Also, if he was in cath lab, he might have had some contrast so that they can screen the heart. And if he had some contrast in cath lab, the kidneys might have taken a hit and he might have gone into kidney failure. And he wouldn't be the first patient that would go into kidney failure after receiving contrast in cath lab, right? So those are questions. Now you're also saying, theoretically, I'm aware he needs cardiac treatment, but this cannot be performed until he gets his neurological functions back. Well, he does need cardiac treatment. Again, this is why I've asked, did he go into catheter lab, right? What did they find there? Does he need follow-on cardiac surgery, depending on the findings? If he didn't go to catheter lab, what's the cardiologist saying why they didn't take him to cath lab, right? Does he need surgical workup for open heart surgery? Are his coronary arteries blocked to a degree that they can't stent them, and he needs to have open heart surgery to get a coronary artery bypass grafts, such as, also known as CAGs. So those are questions you should be asking the cardiologist. Has he made a referral? Has he or she made a referral to the cardiac surgeon? Next, you should be discussing with the ICU team and with the neurologist why they think he's not waking up. Now, from experience, your dad had a cardiac arrest. So that's, that means your dad was very close to death, right? So not waking up after 6 days after someone has been close to death and is critically ill, give him some time, give him some slack, and give him some time, give him some slack to wake up. Are they stimulating him? Are they mobilizing him? Are they doing physical therapy? Let's look at all the common things to begin with that stimulates a patient's brain. But, again, he's been very, very sick. He's extremely vulnerable. Give him some time, and they need to give him some time too. So you're saying, my question is, after 6 days of what I probably consider reflex movement, what is the short-term care plan going to be like, and what will the long-term care plan possibly look like? Well, the short-term plan, as I mentioned, get a neurological assessment, get a cardiologist assessment, with the heart in particular, is he on inotropes or vasopressors, right? Possibly he had a VF or a VT arrest, because that's when you use a defibrillator. If someone's heart stops, you would start CPR straight away. You don't necessarily need to use a defibrillator unless the heart goes into an irregular rhythm then. So if his heart is still impacted and he's on inotropes and sedative, inotropes or vasopressors such as noradrenaline, norepinephrine, adrenaline, epinephrine, vasopressin, dobutamine, milrinone, levophed. If he's on any of that, then it means his heart is probably not contracting properly, right? And it means that his ejection fraction might be poor. Ejection fraction is the contractility of the heart. And after a cardiac arrest, ejection fraction is often impaired. And because the heart muscle is damaged, right? And therefore contractility may not be as good as it was before. So those are questions that need to be considered, and that might also delay him waking up if ejection fraction is low. Other issues are, if his ejection fraction is poor, has he had an ultrasound of the heart? Okay. Does he have a PA catheter or a Swan-Ganz catheter? Are they doing cardiac output, cardiac index studies? Are they measuring his SVR? Are they measuring a mixed venous blood gas to see how well the heart is working and how well the heart is perfusing other organs, and that includes the brain? Right, again, are the kidneys working? Are the liver working? What is the ventilator doing? I presume he's ventilated, with a breathing tube. Can he be weaned off the ventilator? Is he getting physical therapy? Are they stimulating him? Is he getting good basic nursing care, like good mouth care, good nose care, good eye care? Is he getting regular washes? Is he getting turned regularly? Right? Very critical questions here. We are just receiving the standard answer of all we can do is wait, with very little to no explanations of what the next steps could possibly look like. Yeah, look, I think that is to a degree a standard answer, but at the moment it's also very early days after 6 days, very early days. Now, also you did mention he's on heparin. That means he most likely had the coronary arteries block, right? Or if he didn't have them, or he might have had a cardiac stent, and that's why they put him on heparin. So, you got to ask those questions. Why is he on heparin? Why couldn't he just be on Clexane, for example, or Levanox? Very important questions here. I do believe it's not uncommon at all that your dad, after 6 days after cardiac arrest, is not waking up for all the reasons that I mentioned. So you got to give this a few more days. Give your dad time to recover from what is a major critical illness. You can't rush these things. And, as long as they are doing the right things, as long as they've done the MRI scan and the CT scan and the EEG, and that's normal, let them give the anticonvulsants. Maybe they can wean them off in the next few days if they think there's no further risk of seizures. Another thing that you haven't mentioned is, does your dad, for example, have any pre-medical history that potentially prevents him from waking up? Is there something else that's going on that you haven't shared? So, those are all things you got to consider in a situation like that. Got to look at the bigger picture. But I don't think there's any need to panic at the moment unless you haven't shared everything that you needed to share. Let's just go one day at the time. And if your dad still doesn't wake up, contact us here at intensivecarehotline.com. Call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com, and then we can help you from there. Now, let's move on to the next question from Jolene. This is actually a comment that Jolene made on YouTube for one of my videos, and she says, "Hi Patrick, my boyfriend's family fell for the ICU ruse. They cancelled my second and third opinion appointments, shut me out of all consultations, and shut his respirator, and watched him, and now she puts this in quote, peacefully smother and arrest, surrounded by loving family. They informed me at 11 p.m. the next night. Now they all say I am crazy because I held a different opinion and wanted to explore options. They are furious that I have shared the other possibility of recovery with our close friends, and they are now retaliating against me on social media for speaking up. Why won't some people hold on to hope and gather all of the options and possible outcomes? It's been 2 months and I'm still ruminating tears over this every night. Very sad to hear this, Jolene. It's heartbreaking what you've been through. And, unfortunately, people that question when it comes to intensive care treatment are not in the majority, and I can say that, from experience, a lot of good things happen in ICU. As a matter of fact, the majority of things that happen in ICU is very good. But, people are not looking for advice online if things are going well, which is, why I'm sort of dealing with a lot of the negatives in ICU, and obviously you have smelled a rat, for lack of a better term. You obviously thought you needed a second opinion. I presume your boyfriend was very young, and you thought your boyfriend deserves a genuine chance of survival, and maybe his family didn't want to give that to him. And that is extremely sad that you are now dealing with the loss of your boyfriend, and you're also dealing with the quote-unquote retaliation of your boyfriend's family. That is incredibly sad. If you have a loved one in a situation like that, why would you not try everything? It's almost like you've got nothing to lose in a situation like that. And like I always say, the biggest challenge for families in intensive care is simply that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. That's what you're dealing with here. I would think that by you getting access to the medical records, if you can achieve that, we can help you finding out what's really happening. That would be my advice here. That you just try and get access to the medical records. But it's also an issue for anyone watching this. If you have a fiance, a boyfriend, a girlfriend, whatever, you're not legally married, it is an issue that you can't really make any decisions in situations like that. So let's do one more question, and then we'll wrap this up for today. This is an email from Loretta. Loretta says, 8 days ago, my brother-in-law was put in a medically induced coma. He went in by ambulance because he was septic. 2 days ago, they had to give him blood, but they don't know where it's coming from. What does that even mean? Okay, what that probably means is he's bleeding from somewhere and they don't know where it's coming from. So if they had to give him blood, that's what that means. He responds to certain people when we talk to him. He tried to open his eyes. When my daughter, who is his niece, talks to him. He responds to certain people when we talk to him. He tried to open his eyes when my daughter, who is his niece, talks to him. They are extremely close. Can you please tell me what is happening to him, and is he going to die? Please help me to be able to understand. From Loretta. Okay, so great question. So again, coming back to that sort of medical language where they say they don't even know where the bleeding is coming from, and they don't. What happens with patients in ICU? They may not necessarily bleed, but they are getting anemic pretty quickly because the whole immune system is usually lowered in intensive care for patients in intensive care, which means the immune system also stops producing red blood cells, which is why the hemoglobin drops. And it sounds to me like he's come to a critical point where his hemoglobin might have dropped to a point where he might need a blood transfusion. Now, another thing that can happen during sepsis is the clotting factors can play up in the blood, which means patients are at a higher risk of bleeding, generally speaking. His platelets might have come down, might have needed a platelet transfusion. His INR might have gone up. He might have just needed some fresh frozen plasma, but simply his hemoglobin might have dropped as well. So that's one question. He would have, as part of the sepsis, probably, he might have a pneumonia, or he might have had low oxygenation to the organs, which is why they might have started him on mechanical ventilation and in an induced coma. I have actually made a video about this recently, just in the last 24 hours, where I just quickly need to look up the title where your question. Yeah, why is an induced coma necessary for sepsis or septic shock? So your question will be answered if you look at the last quick tip video that I actually published before this video. So, just have a look there. Your question will be answered there. Why he's in an induced coma. Then you're asking, can you please tell me what is happening to him, and is he going to die? Okay, is he going to die? So you might have heard me say this before, but research suggests in ICU that approximately 90% of intensive care patients survive. Now, there is a higher mortality rate for septic patients in ICU, but if you went into ICU, on time, and they started antibiotics or antivirals, whatever, and they found the source of infection, higher chances are your brother-in-law is going to survive this, but then again, generally speaking, the mortality rate in ICU is around 10%, i.e. 90% of patients in intensive care survive and 10% approximately die. Again, the mortality rate for sepsis or septic shock is higher. I believe it's around 30 to 40%, but hopefully, your brother-in-law came in the right place at the right time. And, with sepsis, like I said, what is happening to him? So it's ventilated, it's in an induced coma, he's probably getting some antibiotics, antifungals, antivirals, depending on whether they could source the infection. They need to screen his sputum, his blood, and his urine to see where the sepsis is originating from. Once they know where it's originating from, they need to use the right antibiotic to target the bacteria, right, or the fungus or whatever else this is, or the virus. Next, his blood pressure probably plummeted because of the hypovolemic shock, which often goes hand in hand when patients go into septic shock. Patients often have a hypovolemic shock, so he would have needed some fluid resuscitation, in order to manage that. If that wasn't enough with the fluid challenge, he might have needed, or he still may need, some inotropes or vasopressors to get his blood pressure up, so it comes up to a level that's compatible with life. With the induced coma, he's under sedation, such as propofol, midazolam/Versed, or morphine and midazolam. He will be requiring monitoring very closely in ICU. Hooked up to a monitor, he will probably have a central line and an arterial line. They will need to check his bloods very regularly, once or twice a day. They will need to do arterial blood gases more than once a day, probably every 4 to 6 hours, to manage and look out for the effectiveness of mechanical ventilation. Blood tests in particular will focus on hemoglobin levels, white cell count levels, lactate levels, but also electrolyte levels, coagulation, such as, INR, platelet levels, as well as HPTT, APTT. So, he'll probably be placed on a nasogastric tube so they can start feeding him. They might have inserted a Swan-Ganz or a PA catheter or a Pico catheter to measure cardiac output, measure mixed venous arterial gases, mixed venous blood gases, I should say. and he might have been started on some steroids as well. So, and then hopefully his white cell count is probably very elevated at the moment. He's probably got a temperature, high temperature, and once that can come down, hopefully, you know, with the antibiotics starting, then he should be on his way to recovery. You know, but that can take a while. That can take a while. You've got to be patient here, and take one step at the time. You know, you might need to be in an induced coma for a few days. So I hope that helps, Loretta, to understand you what is really happening there, you know, and hopefully your brother-in-law can recover. So let's wrap this up for today. Unless you have any other questions, you can type them into the chat pad and I will answer those questions right here and then. If you don't have any other questions, I presume, you know, you come back next time or call us. Or, and by the way, if you do have a loved one in intensive care, go to intensivecarehotline.com, call us on one of the numbers on the top of our website, or simply send us an email to support@intensivecarehotline.com. Also, have a look at our membership for families in intensive care at intensivecaresupport.org. There you have access to me and my team 24 hours a day, and we answer all questions intensive care and intensive care at home related. Now, if you need a medical record review for your loved one in intensive care, you should contact us as well. We review medical records in real time for patients in ICU, but also after intensive care, especially if you need closure, you have unanswered questions, or if you simply suspecting medical negligence. We're also providing NDIS nursing assessments for our intensive care at home clients. That leads me to another thing. If you need intensive care at home for your loved one, if they can't be weaned off a ventilator, please contact us as well. If if you want home care instead of being stuck in ICU long term, you should contact us as well, especially if you're in Australia and in the US. We operate all over Australia and all major capital cities, including regional and remote areas. And we have now started in the US as well. You should contact us if you're in the US as well on one of the numbers on the top of our website at intensivecareathome.com, or send us an email to info@intensivecareathome.com. Now, if you like the video, give it a thumbs up, give it a like, subscribe to my YouTube channel for regular updates for families in intensive care and intensive care at home. Click the like button, click the notification bell, and comment below what questions and insights you have from this video. Thank you so much for watching. This is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com, and I'll talk to you in a few days. Take care for now.